All right, diving in today, folks. We're going deep on something that I think a lot of people are curious about, and that is weight loss surgery.
Yeah, it's a big one.
It is a big one.
It is a big one, and there's a lot of different options, and I think there's a lot of, people hear different things. So we wanted to do a really in-depth look at specifically 3 of the most common procedures. So sleeve gastrectomy, you've got your Reon-Y gastric bypass.
Oh, yeah, that's the one everyone's heard of.
Right, that's the classic. And then the mini gastric bypass, which is sort of the up-and-comer. And so what we're doing is looking at a study that was published back in 2015. And this was a 7-year clinical audit.
Okay.
Meaning they followed over 1,000 patients, 1,107 to be exact,
Wow.
for 7 years
That's a significant.
after their surgeries
Yeah.
to see, how do they actually do?
Real world data.
Yeah, like cut through all the marketing jargon.
Yeah.
What does it really look like?
And I think that's really important because you see a lot of anecdotal stuff about, oh, this person had this surgery and they lost a ton of weight.
Right.
But we never hear about the people who maybe didn't have as good of an outcome.
Right.
So it's important to see, okay, what is the data actually showing us about how effective and how safe these procedures are?
Right.
And this wasn't like, some small study in like a research facility somewhere. This data is coming from Jammu Hospital in Punjab, India. And what makes that particularly interesting, and you can probably speak to this better than me, but Punjab has a very high prevalence of obesity.
It does.
So you're getting a really concentrated,
Like a little microcosm
yeah,
of these procedures
yeah,
in a population where they're more common than in other places.
Yeah.
Yeah. So it's a really good sample size.
Yeah.
And a long time. 7 years is a really long time
absolutely
to follow people.
So when they were following these folks, what kinds of things were they looking at?
So they were looking at a lot of the things you would expect. So of course they looked at how much weight people actually lost.
Yeah.
Which is, that's kind of the point, right?
Yeah.
But then also, crucially, they were looking at whether or not these related health problems, like type 2 diabetes, high blood pressure,
Right.
high cholesterol.
Which are huge for this, yeah.
Huge. Like, did those things get better?
Yeah.
Or go away?
Mm-hmm.
And then also, like, what kind of complications arose?
Right.
So, it's kind of like the good, the bad, and the ugly.
Absolutely.
That's what they were trying to look at.
All right. So let's break down each of these surgeries.
Yeah.
First of all, because like I said, the names can be a mouthful, and I think it would be good for us to just clearly explain what's going on.
Absolutely.
First up is the laparoscopic sleeve gastrectomy, or LSG.
LSG, right.
So LSG, what is that in a nutshell?
Okay, so in a nutshell, the sleeve gastrectomy is primarily a restrictive method.
Okay.
And the way it works is that they actually go in, they remove a large portion of your stomach.
Okay.
And what's left is just this sort of smaller, tube-shaped stomach, which they call the sleeve.
Got it.
And so what that does is that it basically just dramatically limits how much food you can eat.
Okay.
Comfortably.
Makes sense.
And it's important to know this is generally considered a permanent change.
Right. So for this study, how many folks underwent the sleeve gastrectomy?
Let me see. 339 patients had LSG.
Okay.
And their average BMI was about 35.
Okay. And just so folks know, a BMI of 30 or higher is generally considered obese.
Right.
So we're talking about, folks who are starting out, already in that obese range.
Right.
Okay. Next up, we got the one that I think a lot of people have heard of, the Roux-en-Y gastric bypass.
Yeah, the classic RYGB.
RYGB, right. So this seems like a little bit more plumbing going on in this one.
Yeah, it does. It does. So the Roux-en-Y gastric bypass combines restriction with malabsorption.
Okay.
Right. So what they do is they create a small pouch from your stomach.
Okay.
You can almost imagine they create a new tiny stomach.
Yeah, okay.
But then in addition to that, they actually reroute your digestive tract.
Whoa.
So that it bypasses a portion of your small intestine.
So not only are you eating less,
right,
you're absorbing less of what you're eating.
Right. You're getting a double whammy there.
Yeah. Okay. So for the folks in this study who had the Roux-en-Y, what did their stats look like coming in?
Okay, so the Roux-en-Y group, they had 295 patients.
Okay.
and their starting BMI was a little bit higher than the sleeve group. It was around 42.5.
Okay.
So a little bit higher level of obesity to start with.
Got it. Okay. And then finally, we've got the mini gastric bypass.
The MGB.
Or sometimes it's called a one anastomosis gastric bypass.
Right.
So what makes this one different from the other two?
Okay. So the MGB also uses both restriction and malabsorption.
Mm-hmm.
So in that way, it's similar to the Roux-en-Y.
Okay.
But the key difference is in how the stomach is connected to the small intestine.
Okay.
So in the Roux-en-Y, they actually create like a separate pouch.
Right.
And then there are two connections to the small intestine.
Right.
With the mini gastric bypass, they create this long, narrow pouch from your stomach.
Okay.
And then there's just one connection.
Got it.
One anastomosis, which is just a fancy word for connection,
to
a lower part of your small intestine.
Okay.
So it's simpler in a way than the Roux-en-Y.
Okay. Got it. And it looks like the study had a decent number of mini gastric bypass patients, right?
Yeah. So the mini gastric bypass group was actually the largest group in the study.
Oh, wow.
With 473 patients.
Okay.
And their average starting BMI was actually the highest of all three groups.
Yeah.
It was a significant 56.5.
Wow.
And I think it's interesting to note that this procedure was actually pioneered back in 1997 by a surgeon named Robert Rutledge.
Oh, okay. So it's not brand new.
No.
But it is, I guess, gaining in popularity.
It seems to be.
Yeah.
Yeah.
Okay. And it's interesting as you were talking about the different groups. It seems almost like maybe the choice of surgery was kind of tailored to how heavy the patients were.
Oh, yeah.
To start with.
Yeah.
Would you say that's accurate?
Absolutely.
Yeah.
I mean, a lot of times a patient's initial BMI, along with their, other health conditions, play a huge role in deciding what procedure is going to be right for them.
Makes sense.
They also, in the study, they noted the average time it took for each surgery.
Oh, okay.
Which can, give you a little sense of the complexity
of
each one.
Yeah.
So the sleeve gastrectomy took about an hour on average.
Okay.
The Roux-en-Y, considerably longer.
Okay.
About 2 hours and 40 minutes.
Wow.
While the mini gastric bypass was relatively quick.
Okay.
Just under an hour.
Interesting.
On average.
Okay, so let's get to, I guess, the stuff that everyone really wants to know about, right?
The outcomes.
Yeah, the outcomes. Let's start with the serious stuff.
Yeah.
So mortality.
Right.
And then any kind of complications that these patients experienced. What did this audit find?
Okay, so sadly, the sleeve gastrectomy group had the highest mortality rate.
Ooh.
At 2.1%.
Okay.
The Roux-en-Y had a much lower rate, 0.3%.
Okay.
And remarkably, the mini gastric bypass group, they reported 0 deaths.
Wow. Okay.
Yeah.
That's a pretty significant difference.
It is. It is.
What about leaks? Because I know that's a big concern.
Yeah.
After surgery.
Leaks are definitely a big concern.
Yeah.
And they were indeed the most frequent in the sleeve gastrectomy group.
Okay.
At 1.5%.
Okay.
Roux-en-Y saw a much lower rate, again, 0.3%.
Okay.
And once again, no reported leaks in the mini gastric bypass group.
Oh.
Yeah. And the study authors, they actually speculated that the higher pressure within the narrow sleeve after a gastrectomy might contribute to that.
Makes sense.
Whereas the single but wider connection in the mini gastric bypass could be a factor in its lower leak rate.
Right. That makes intuitive sense.
Yeah.
All right. So what about, were there any other complications that you thought were particularly noteworthy?
Yeah. So one thing that was interesting is that persistent vomiting was only noted in one patient in the sleeve gastrectomy group. And unfortunately, this led to a serious condition called Wernicke's encephalopathy. Which is caused by a severe vitamin B1 deficiency. And then bile reflux, where bile flows back up into the stomach, was seen in a small number, less than 1% of mini gastric bypass patients.
Got it. Okay. And what about weight regain?
Oh, yeah.
Because that's a big concern, right?
Sure.
For people considering these surgeries. It's like, okay, I'm going to go through all of this.
Right.
Am I going to be able to keep the weight off?
Right.
So what did the study show us about that?
Well, unfortunately, they did find that weight regain was most common after sleeve gastrectomy.
Really?
Yeah, at 14.2%,
Okay.
followed by Roux-en Y at 8.5%.
Okay.
But interestingly, there was no reported weight regain
Wow.
in the mini gastric bypass group
Wow.
over those 7 years.
So 0%.
Yeah, 0% weight regain in that group.
That's incredible.
It's pretty incredible.
Yeah.
And the researchers, they suggested that maybe this is because the sleeve can kind of stretch out
Okay.
over time
Oh.
in the LSG group.
Yeah.
And in the RYGB, the pouch or the outlet can dilate.
Okay.
So it's like they sort of lose some of their restrictiveness.
Interesting. Okay. So, I think one thing that's important to talk about is that, these surgeries, they can really impact how your body absorbs nutrients.
Oh, absolutely.
So what did this study find in that area?
Yeah. So they looked at a few different things.
Okay.
So one thing was hypoalbuminemia,
Yeah.
which is just a fancy word for low protein levels
Okay.
in your blood.
Okay.
And that was minimal.
Okay.
In the sleeve gastrectomy group,
Okay.
occurred in 2.0% of the Roux-en-Y patients,
Okay.
but was more prevalent, more common
Okay.
in the mini gastric bypass group at 13.1%.
Oh, wow. Okay.
Yeah. And the study authors found that this was often linked
Okay.
on how long
Okay.
the bypass section of the small intestine was
Got it.
in the MGB. And they noticed that the longer bypasses, so greater than 250 centimeters,
Okay.
were more likely to lead to low protein.
Got it.
And those longer bypasses, they were more common in the earlier cases
Okay.
when they were first doing the surgery.
Okay.
And also for patients
Yeah.
who had super, super high BMIs.
Right.
But the good news is that usually managing this
Okay.
with a high protein diet
Okay.
was enough.
Okay.
In a very small number of cases, about 3.2%
Okay.
of the MGB patients,
Yeah.
they had to consider reversing the procedure.
Okay.
But, really highlights the importance of
Yeah.
careful surgical technique
Yeah.
and monitoring those patients.
Absolutely. Making sure they're
Yeah.
getting the right nutrition.
Exactly.
Okay. So it sounds like the surgeons were kind of learning as they went too
They were.
and adjusting their
Exactly.
technique.
Okay.
Okay. That's good. What about anemia? So low iron levels.
Yeah, so anemia was also observed.
Okay.
And the highest rate was actually in the mini gastric bypass group, 4.9%.
Okay.
Followed pretty closely by the Roux-en-Y, 4.8%.
Okay.
And then the sleeve gastrectomy, 3.5%.
Okay.
And this is often because, bypassing a portion of your small intestine
Right.
can reduce the absorption of iron.
Yeah.
Also, the reduced stomach acid
All right.
after some of these surgeries can also hinder
Got it.
iron absorption.
So it's like a double whammy on that one.
Kind of, yeah.
Okay. And then what about GERD?
GERD.
Gastroesophageal reflux disease.
Yes.
More commonly known as acid reflux.
Heartburn.
Yeah.
Yeah, so interestingly, that was most common
Okay.
after sleeve gastrectomy,
Huh.
with 9.4%
Okay.
of patients reporting it.
Okay.
Roux-en-Y had a much lower rate, 1.7%,
Okay.
and mini gastric bypass had the lowest
Okay.
at 0.6%.
Wow.
Yeah.
Okay. And why do you think they have any theories about why that is?
They think it's likely due to the changes in pressure
Okay.
within the stomach
Okay.
and the way the food moves through the system after those different surgeries.
Makes sense. Okay. Any other complications worth mentioning?
Yeah, so a few others.
Okay.
Internal hernia,
Okay.
which can be a serious condition
Yeah.
where the small intestine can get twisted.
Oh.
That was only seen
Okay.
in the Roux-en-Y group,
Okay.
affecting about 2%
Okay.
of those patients.
Got it.
Dumping syndrome,
Okay.
where the stomach contents empty too quickly,
Yeah.
can cause those really unpleasant symptoms,
Yeah.
like the nausea, the diarrhea.
Right.
That was reported in about 2.7% of Roux-en-Y patients
Okay.
and 5.9%
Okay.
of mini gastric bypass patients,
Okay.
but not at all in the sleeve gastrectomy.
Okay.
And then finally, gallstones
Okay.
were most common
Okay.
in the mini gastric bypass group,
Yeah.
affecting 8.3% of the patients.
Interesting. Okay. So we're seeing a lot of different potential complications.
Right.
Each one seems to have its own kind of profile.
Exactly.
Okay. Let's switch gears to the positive.
Yes.
So the weight loss.
Right.
That's what we're here for, right? So what did the study show about how much weight these patients were actually losing?
Yeah, so this is actually where we see some really significant differences.
Okay.
So the average percentage of excess weight loss,
Okay.
or percent EWL,
Okay.
was highest in the mini gastric bypass group
Okay.
with an impressive
Okay.
92.2%.
Wow.
Yeah. Roux-en-Y achieved 72.3%.
Okay.
And sleeve gastrectomy resulted in 53.6%.
Okay.
So, really, really striking difference
Yeah.
there.
Yeah, those are definitely numbers that stand out.
Yeah.
Okay. And what about the resolution of those other conditions we talked about? The high cholesterol,
Right.
the diabetes,
Right.
the high blood pressure.
Yeah, so the study looked at how often those conditions improved
Okay.
or went away
Yeah.
after surgery.
Yeah.
And again, the mini gastric bypass really consistently
Okay.
showed the best outcomes.
Interesting.
So for dyslipidemia, that's just high cholesterol.
Okay.
That resolved in 93.4% of mini gastric bypass patients,
Okay.
75% of the Roux-en-Y group,
Okay.
and only 55.8%
Okay.
in the sleeve gastrectomy group.
Got it. Okay. So what about type 2 diabetes?
Yeah, type 2 diabetes.
Yes.
So the results here were they were truly remarkable
Okay.
with the mini gastric bypass.
Okay.
So 94.4%
Wow.
of patients in that group
Yeah.
were able to stop taking their diabetes medication.
That's incredible.
It's pretty incredible.
Yeah.
And the remission rates were also good.
Okay.
For Roux-en-Y, 76.2%.
Okay.
And sleeve gastrectomy, 59.4%. But the mini gastric bypass results,
Yeah.
those were exceptional.
Wow.
And the study authors, they actually described these as spectacular results
Okay.
for type 2 diabetes with mini gastric bypass.
Yeah.
And they believe this is because of kind of a combination of things.
Okay.
So it's the smaller stomach size.
Right.
It's the faster movement of food,
Okay.
which seems to affect gut hormones.
Right.
And there's something called the incretin effect,
Okay.
where basically your gut tells your pancreas
Okay.
to release insulin,
Okay.
and then also, the malabsorption of fat.
Right.
So all those things kind of working together.
So it's like a whole cascade of events.
Yeah, a symphony.
Yeah.
A symphony of metabolic changes.
Yeah. That is really fascinating.
Yeah.
Okay, so what about hypertension?
So for high blood pressure,
Yeah.
85.4%
Okay.
of the mini gastric bypass group
Yeah.
saw their high blood pressure resolve.
Wow. 72.3% in the Roux-en-Y group
Okay.
and 46.7
Okay.
in the sleeve gastrectomy group.
So across the board,
Yeah.
mini gastric bypass seems to be doing
Right.
the best
In this study.
at resolving
In this study, yeah.
these related health issues.
Right.
Okay. So after looking at all of this data, what were the researchers themselves?
Right.
What were their main conclusions?
Yeah. So based on their 7 years of experience with this,
Yeah.
they concluded that the mini gastric bypass
Okay.
appears to be a really effective
Okay.
and safe procedure,
Yeah.
particularly for patients who they felt would be reliable
Okay.
in taking the necessary supplements.
Always.
Because remember, we talked about those nutritional deficiencies,
Right.
so that was a big caveat
Right.
for them.
Yeah. So what about the folks who maybe weren't so good at
Right. Yeah.
taking their supplements? Yeah. So for those folks, they suggested that maybe the laparoscopic sleeve gastrectomy
Okay.
might be a better option,
Okay.
even if those patients were willing to accept
Yeah.
that they might not lose as much weight
Right.
and might be more likely to regain it.
Got it. Okay. So it seems like they're really leaning towards
Yeah.
the mini gastric bypass.
They did state that both the Roux-en-Y and the mini gastric bypass
Okay.
achieve their results through the restriction and the malabsorption.
Right.
But they felt that the mini gastric bypass
Yeah.
really kind of superseded
Okay.
the Roux-en-Y in a few key ways.
Okay.
So it was easier to do surgically.
Okay.
It was more effective overall
Okay.
in terms of the weight loss and the resolution of those other issues.
Yeah.
And then also it was more easily adjusted or even reversed if needed.
Okay.
So they felt like it was a superior technique.
So, I mean, I'm hearing you really emphasize this supplement compliance thing,
I am.
especially for the mini gastric bypass.
It's huge.
So what is it like? What are they having these patients take?
Yeah, so they really emphasize the importance of, especially for those mini gastric bypass patients, taking calcium, taking iron,
Okay.
because of that malabsorption
Right.
component of the
Right.
surgery.
Right.
And they actually noted that, over the years, they've kind of tweaked their technique with the MGB.
Okay.
So that they're typically using shorter lengths for the bypassed intestine now.
Okay.
So around 200 centimeters.
Okay.
But up to 250 centimeters for, folks with very high BMIs or maybe longer small intestines to begin with.
Right.
And that's all to try to minimize that risk of low protein,
Okay.
that hypoalbuminemia.
Got it. Okay. So I mean, wow, this has been a really, I think, eye-opening look at these surgeries.
Yeah.
So I guess to kind of sum it up, we've done this deep dive into this 7-year clinical audit.
Right.
And it's really given us some insight into how these 3 weight loss surgeries performed in a real-world setting.
Yeah, absolutely.
At least at this one hospital in India.
Right.
But, I think the takeaway is that, at least in this audit, the mini gastric bypass really showed some significant advantages in terms of how much weight was lost.
Right.
And the resolution of those related health problems.
Absolutely.
And remarkably, they had 0 deaths
Yeah.
in their mini gastric bypass.